Okay, good afternoon, everyone. Hope you enjoyed your lunch and didn't speed eat. We wouldn't want any fat pads arising from, oh, okay, sorry. A little after lunch humor. Okay, so we're going to go ahead and continue with the diagnosis proposals. And at this point, I'm going to turn the podium over to Shannon, who will lead the discussion on the topic. Shannon? Here.
Good afternoon. If you turn to page 65, the topic is osteoporosis-related pathological fracture of rib and pelvis. This is a representation. This is a revised proposal based on comments that were received following the March 2017 Coordination and Maintenance Meeting. Decision Health, a home health consulting company, is requesting the following tabular changes in order to capture these conditions. At category, we're on page 65. At category M80, osteoporosis of current pathological fracture. At subcategory M80.0, age-related osteoporosis with current pathological fracture. Adding a new code M80.09 to read age-related osteoporosis with current pathological fracture, other site. A new code M80.0A for age-related osteoporosis with current pathological fracture, rib, and a new code M80.0B, age-related osteoporosis with current pathological fracture, pelvis, with 3 inclusion terms, ischium, ilium, and pubis. And at subcategory M80.8, we're proposing a new code M80.89, other osteoporosis with current pathological fracture, other site. A new code M80.8A, other osteoporosis with current pathological fracture, rib. and a new code M80.88B, other osteoporosis with current pathological fracture pelvis, again with the 3 inclusion terms, ischium, ilium, and pubis. Are there any questions or comments on this proposal here in the room? Okay. Moderator, would you please open the lines for any questions?
All lines are now unmuted.
Are there any questions on the line? Okay, hearing none. You could go ahead and mute the lines again. We will move on to the next topic, which is on page 63. And before I actually go into the clinical background piece, I would like to just invite up for, in the event that we have some clinical questions here, I'd like to invite Dr. DeFabio, who is a member with the American Association of Oral and Maxillofacial Surgeons, to come up. I'll go ahead and go through the background portion of it a little, or do you want to just go ahead and start with this one and then do the slide? Introduce one? Okay. He'll provide the clinical background, and then we will go through the tabular modifications. Okay. Yes, and if you just do the background, then I'll tie that into the one we just did.
Okay, under very similar circumstances as the past report, the American Association of Oral Maxillofacial Surgeons, the AAOMS, is proposing the creation of new codes for pathological fracture of the jaw due to age-related osteoporosis and pathological fracture of the jaw due to drug-induced osteoporosis. While there is a code for multiple types of fractures within each subcategory, the fracture of the jaws, the maxilla, and the mandible is not listed. The closest entity and entry is directed to the code of M80.00, age-related osteoporosis with current pathological fracture. Unspecified site and code M80.80, osteoporosis with current pathological fracture, unspecified sites.
Are there any clinical questions for Dr. DeFabio before I go over the tabular background for the osteoporosis fracture of the jaw? Okay, I'll go through the tabular modifications. Dr. Berglund, we're on page 63 still for the osteoporosis-related pathological fracture of jaw from our topic packet. Okay. Could we, Dr. Berglund, could you switch it back over for the screen here to be on the topic packet?
Okay, wait a minute.
Page 63. Okay. 80 point. Okay. All right. So at category M80, osteoporosis with current pathological fracture. Subcategory M80.0, age-related osteoporosis with current pathological fracture. If we recall in the prior proposal that we just went through for the rib and pelvis, there was a proposed new code M80.09 for other site. So here we're proposing a new subcategory, which would be M80.0C, age-related osteoporosis with current pathological fracture mandibular, with new codes for laterality. So the change here is that this group is requesting that further breakout for laterality. Also, a new subcategory M80.0D for age-related osteoporosis with current pathological fracture of the maxilla. Same pattern for capturing the laterality. A new subcategory M80.8C, other osteoporosis with current pathological fracture, mandibular. This is under the subcategory of M80.8 for other osteoporosis with current pathological fracture. And then that subcategory was the osteoporosis with current pathological fracture. So also the last new subcategory being proposed is M80.8D, other osteoporosis with current pathological fracture, maxilla, with, again, the further breakout for the laterality. Are there any questions or comments here in the room?
This is a clinical question, actually. What is the value of having the laterality for the left and right mandible and left and right maxilla? Am I wrong, or are those just single bones?
The right, the left, bilateral,
Well, the maxilla and the mandible are both broken into right side, left side, or
Right.
both sides, right? So that just gives us better classification and determination and documentation of which side of the jaw is that fracture on.
And that
I
that
mean,
has the value in terms of the data, of
the
studying it?
data accumulation, certainly. Yeah, there's multiple areas of a jaw, mandible, or maxilla where there can be fractures. So there can be a right condyle, it can be a right angle, it can be a right body, it can be the right parasymphysis. If we don't specify where that is, and even break that down even further, then the fracture of the jaw is kind of meaningless. It doesn't give us right or left.
Okay, I'll think it over. Thanks.
Lynn Keene Consulting. And while I appreciate what you just said, it's interesting that in the procedure code set for the inpatient side, for this October 1st, we removed the laterality on the maxilla. And so it's very hard for coders who don't normally deal in procedures, especially on this, to determine from the tooth number whether you're right or left. And so I understand that's not your issue, that's a coding issue. But it's interesting that we have just found there was a problem and needed to go backwards and remove that laterality, and here we would be adding that level of detail.
Right. Thank you.
If you're specifying tooth numbers, that's different than right or left maxilla or right or left mandible, because the tooth numbers could be involved or could not be involved. And sometimes with osteoporosis, there could be no teeth involved at all. That becomes a real problem.
Nellie Leon, She's American Hospital Association. I just want to follow up on what Lynn has said, because I think for coders, we're going to have trouble figuring it out, just like we had on the procedure codes. So what happens if it's a fracture of the chin? Let's say it's right in the middle. How do you determine left or right? Because we're not going to know to count teeth or anything like that. And so with the procedure classification, when we had left or right and we had things like that where it was a single organ and something happened that was in the middle, we were having to decide, even maybe assigning both codes, right and left, because it was right in the middle. So I'm not sure how often that happens with the maxilla and mandible, but I think that as coding professionals, we're going to be in the same boat that we were for the procedure, unless there's some, because I didn't know you would count the teeth, and how would it be determined and how would it be documented in the record?
Yeah, more likely than not, the chin fracture is in the midline specifically, or the maxilla in the midline. They can certainly happen, but the incidence of fractures to that area specifically is low, very low, versus the condyle fracture or angle fracture, which is very high. So that would be more posterior in the mandible or maxilla. And so I think that's one of the reasons.
Thank you. I'll make a note that we definitely need to keep that in mind going forward for how we would handle those situations. Yes? Sorry.
I just wanted to clarify. I'm actually clarifying Lynn's comment, and I hope I get this right. Tell me if I don't, Lynn. When she was commenting about the tooth number, she wasn't intending to say that the fracture involves the socket of the tooth. What she was saying is that in the operative reports that we read, I'm sure you personally always document right and left. However, some of your colleagues may not. And what they say is the fracture occurs between this tooth and that tooth. So, you know, I really have to go to my dentist and get that picture with all the teeth numbered so I can figure out where this fracture is. They don't tell me if it's left or right. They say it's between here and here, and that's very specific. I understand why they say that. And I never actually cared a whole lot before because it was just a mandible. It was a maxilla. It's a single bone. But now, if we break it out between left and right and bilateral, and, you know, I think what you're going to have most of the time is codes that end in 9 for unspecified, because I don't have time to sit there and count the teeth and learn, you know, that calculus.
Yeah, it also depends on which coding system you're using. That's the other problem. So you have international, you have U.S. system, you have ABC system in pediatric children, which is another problem. So yeah, that's having the teeth numbers is probably not the best thing to use, but to use basically left or right. That would be much simpler for everybody. I'll tell them. We do.
All right, I don't see any other comments or questions here in the room. Moderator, could you please open the lines for any questions?
All lines are now unmuted.
Are there any questions on the line? Any comments? Okay, hearing none. You can go ahead and mute the lines, and we will move on to the next topic. It is on page 78, and the topic is mandibular joint. Dr. DeFabio does have a slide deck, which he will go through with us. He's going to switch it over.
This is. Nope, this one was working. It worked for the first one.
Dr. Berglund, is it only the... Let me make sure.
These buttons should let you go forward or backward.
Okay, okay.
Or, well, it's not going backward now. Okay, yeah, it does,
Okay.
you might have to hold it up high.
Okay.
It may not go through this, and it controls
Come
down to there anyway.
Okay.
And this has a pointer.
Thank you. Thank you again. And this is, again, a presentation from an ask from the American Association of Oral Maxillofacial Surgeons, commonly known as AAOMS. And this is a presentation for new and expanded ICD-10 CM codes involving the temporomandibular joint. So instead of listing every one of the asks that we have here, I thought I would just do an overview of the temporomandibular joint, a little bit of anatomy, a little bit of function, a little bit of pathology that's involved in this joint per se. So what is the temporomandibular joint? This is a gliding, sliding, double joint complex system of the craniomandibular complex. So they're basically two separate operating joints that are attached to the mandible and, of course, to teeth when we do have the teeth there. And it works usually in harmony with the maxilla and the dentition for multiple purposes: function, eating, chewing, speaking. Attached to the double joint complex are multiple masticatory muscles on each side, closing and opening muscles. And these are involved in the chewing cycles and, of course, in the range of motion. Damage to one or both of these joints can lead to debilitating acute pain, chronic pain, dysfunction of the complex, internal joint pain, muscle pain, degenerative joint disease, etc. And this is a very, very busy slide, and I put this up here on purpose because this is a double joint. And if you look here, we can see that this is an MRI which shows the dislocation of the disc in an anterior position, totally dislocated disc. This is a superior joint space. This is the bone of the MRI. This is a one of my assistants pointing to the temporomandibular joint. It's a small, small little area, but in that small area, we have everything under the sun, basically. We have skin, subcutaneous tissue, fat tissue. Ear is just posterior to this area with the tympanic membrane and ossicles. The tympanic joint itself has a lateral and a medial capsule. We have the temporomandibular meniscus or pad or disc that sits there between the skull bone and the joint itself. And we have all these other things that are listed. So there are multiple entities that can have pathology and can cause pain and dysfunction in the patient. Temporomandibular joint dysfunction or disorders, as it's called, are a collection of all the possible maladies of the craniomandibular complex involving muscles of mastication, the accessory muscles that are attached to the head and to the skull. We have involving soft tissue pathology like parotid tumors, parotid infections. Involves odontogenic, so we talk about teeth being related to the mandible and the maxilla. Well, those teeth can cause pathology. The pathology can go distal and up to the temporomandibular joint and cause dysfunction with that temporomandibular joint as well. It involves degenerative joint-specific disease as in osteoarthritis, osteoarthrosis, and degenerative joint changes. And it involves the synovial membrane, so we can have synovial membrane pathology, we can have tumors, we can have meniscus abnormalities like I showed you on the last x-ray with anterior displacement of the disc, and many, many other pathologies that can occur. Now, why do we want to bother with this problem? Well, it affects about 30% of our population, and about 5 to 10% will need or have some kind of surgery as a remedy for their pathology and their condition. It affects women 80% to men 20%. It's a debilitating disease, and if you've had it, you know that it can be problematic, as you can't eat, you can't chew, you can't talk, and you really have a miserable time. And this can lead then to a total joint replacement, as in the knee or the hip. Very little information is gathered from dental school and dental students on this pathology, and also very little information and knowledge and experience in treating these patients occur in most oral maxillofacial surgery training programs. Actually, oral and maxillofacial surgery is usually the only specialty that treats this kind of malady. Lucky for us in the state of Maryland, we have a very good University of Maryland School of Dentistry and Oral Surgery department where we have tremendous access to temporomandibular joint understanding and pathology and also treatment with surgical intervention when necessary. This is an overlap with multiple problems, compounds, and the ability to obtain a specific diagnosis is always a problem trying to figure out what is the real problem. So we come in with a problem. It can be any one of these. It can be a psychological problem. It can be a myofascial or a muscular problem. It can be a problem of the internal pathology like we showed with the MRI showing a dislocation. It can be systemic. We can have rheumatoid problems. We can have degenerative joint problems. We can have collagen vascular tumors. It can be a neuro problem, so central pain. It can be specific pain internally in the joint. And it can involve other pathologies of the bone, soft tissue, tooth, and genetic disorders, such as craniomandibular dysostosis with golden horse syndrome and many, many other abnormalities of the temporomandibular joint. So pathology is one. Bone, soft tissue, genetic disorders is another. Local pathology within the temporomandibular joint, specifically to that joint. And you saw a picture of my assistant holding her finger in front of her joint, pointing right to where the pain was. It was right specific there. It can be myofascial, so we ask for myofascial entities, specifically instead of just having a head and neck pain or myalgia, we want to have specific muscles that are involved. So whether we know whether or not it's a multiple neuromuscular disorder, or there is trigger points that can be taken care of, or it is a true internal derangement. And of course, there's some psychological overlay, so we have to be cognizant of that as well. The problem with diagnosing is that all these can overlay at the same time. and this is why we need separation. To get the correct diagnosis, this is going to lead to the correct treatment plan, whether it be conservative treatment plan when medically necessary for some type of myofascial problem. It can be the correct surgical treatment when it is medically necessary for the internal derangement that you saw on that patient with the MRI. If we have an incorrect diagnosis, this leads to a lot of problems, as we all already know, and can cause problems with misdiagnosis, with mistreatment, missurgery, everything. And we need to eliminate that as an entity. We ask that the CDC please accept these changes and additions to the ICD-10 10CM for the distinct purpose of providing the correct steps for making the correct diagnosis for the temporomandibular joint disorders and temporomandibular dysfunction. Thank you very much.
Are there any clinical questions for Dr. DeFabio before we go through the tabular modification? Okay, so we will take a look at the tabular modifications, page 78. Okay, so at category M05, rheumatoid arthritis with rheumatoid factor. At subcategory M05.8, other rheumatoid arthritis with rheumatoid factor. A new subcategory M05.8A, other rheumatoid arthritis with rheumatoid factor, mandibular joint, with new codes for laterality, right, left, bilateral, and unspecified temporomandibular joint. At category M06, other rheumatoid arthritis, subcategory M06.0, rheumatoid arthritis without rheumatoid factor. A new subcategory M06.0A, rheumatoid arthritis without rheumatoid factor, temporomandibular joint with new codes for laterality. At subcategory M06.8, other specified rheumatoid arthritis, a similar pattern. And at category M08, juvenile arthritis, subcategory M08.0, unspecified juvenile rheumatoid arthritis, similar codes to capture right, left, bilateral, and unspecified temporomandibular joint. At subcategory M08.2, juvenile rheumatoid arthritis with systemic onset, new codes for reporting laterality. At subcategory M08.4, polyarticular juvenile rheumatoid arthritis. At subcategory M08.8, other juvenile arthritis. 4 new codes for reporting laterality. The same pattern would appear at subcategory M08.9 with the new title reading new subcategory M08.9A, juvenile arthritis unspecified temporomandibular joint. At category M12, other and unspecified arthropathy. Under subcategory M12.5, at subcategory M12.8, subcategory M12.8A, other specified arthropathy, not elsewhere classified, temporomandibular joint with the same pattern, capturing the laterality. This same pattern would be at category M19, other and unspecified osteoarthritis, at subcategory M19.0, at subcategory M19.1, at subcategory M19.2 for secondary osteoarthritis of other joints. Again, 4 new codes capturing the laterality. At category M24, other specific joint derangement, subcategory M24.0, at subcategory M24.1, at subcategory M24.2 for disorder of ligament, at subcategory M24.3. Same pattern continuing at subcategory M24.4, subcategory M24.5, contracture of joint, at subcategory M24.6. There, for the ankylosis of joint, there would be a further breakout, one for a new subcategory M24.6A for bony ankylosis, temporomandibular joint, and a further breakout for the fibrous ankylosis, temporomandibular joint, with 4 new codes capturing laterality. Same pattern would continue at subcategory M24.8, at category M24 for other joint disorder not elsewhere classified. Same pattern appearing at the following subcategory levels: M25.0, M25.1 for the fistula of joint, M25.2, M25.3, other instability of joint, M25.4, subcategory M25.5, and subcategory M25.6. Add category M26 for the dental facial anomalies. The subcategory there that would be affected would be M26.6 breakout. And at category M65, a breakout, again, for the laterality of these temporomandibular joints. I see someone is already at the mic, so I will open the floor for questions and comments.
Jean Yoder, contractor to the Defense Health Activity. Just because you can doesn't mean you should. And here it is. I have providers, including dentists, who say, you know, I just need a little code like pain, joint. And the TMJ pain, I can see because, yeah, a lot of people come in for that. But then I start seeing the rest of these, and I'm going, in the entire Department of Defense, how many times a year would I see a dentist who would document and a coder who would be persistent enough to go and find some of these things as opposed to pain? And so all of these different kinds of arthritis and all this other kinds of stuff, is it going to be treated differently? Is it really going to make a difference? And people go, oh, but the massive data. And the answer is, okay, this insurance company does not share their data with this one, and CMS doesn't even cover it, and the Defense Health Agency doesn't share with anybody else. And I'm thinking, okay, so you're going to get, and we have 9.6 million beneficiaries, okay, so I thought we had a pretty big clump, but I'm looking at these, and even with 9.6 million beneficiaries, I don't see many of these codes being used even once a year, okay, because it's not going, the people, it's not going to be documented, and nobody's going to go that depth to code it because they have got another patient waiting to be seen. So I'm just saying that just because you can ask for it doesn't mean you should, okay?
Well, an answer primarily to that asking question is if we don't have it, it's never going to be documented. And again, going back to the same story, pain can be pain anywhere in the head and neck region, and it could be cranial pain. It could be something totally different than temporomandibular joint pain, and that's the whole aegis of doing this, is to try to be specific and to be documenting everything that needs to be documented to make that specific code and specific diagnosis.
Thank you. Another question? A comment or coding or clinical?
I'm Linda Holtzman from Clarity Coding. I have two comments. One is technical, and the other is philosophical. I'm going to get philosophical like Gene. I'll do the technical comment first, which is we have code M2669 for other specified disorders of temporomandibular joint. You're going to need about 50 exclusion notes on that. Okay? And even if you put 50 exclusion notes on that, I guarantee you that most of the code you get will be M2669 for the exact reason that Gene stated. And that leads to the philosophical point, which is that I understand what you're saying, doctor, I do, but it's kind of a chicken and egg thing. And, you know, like if we don't have the codes, will people bother to specify? If they do specify, should we have codes? You know, so I get that. But the point is that ICD-10 fundamentally does not create diagnoses. ICD-10 fundamentally reflects diagnoses. You create those diagnoses, you physicians, give us those diagnoses, and at some point, ICD-10 will reflect that. But until we actually see those diagnoses in the documentation, then ICD-10, there's no role for ICD-10 in that. We code what we see. So if the literature is moving in this direction, and physicians are now being requested to be this specific, even though, by the way, you point out that it's difficult to determine the exact cause, and it could be a combination of problems. So we could have, you know, 12 of these codes on the same chart for a patient who's coming in for TMJ surgery or treatment or whatever. If the literature is exhorting physicians and dentists to do this and to be this specific, then ICD-10 will follow. But ICD-10 doesn't lead. We reflect. We don't create.
All right. Our moderator, would you please open the lines up for any questions or comments?
All lines are now unmuted.
Are there any questions or comments on the line? Okay, hearing none. Thank you. I will go ahead and we will move on to the next topic. I'm getting ready to do that now, so I'll just let them know what page and, no, don't go for it. I'm going to let you come back up here. So, okay, if you could please turn to page 55 in the handout. Dr. DeFabio will come over and give us some clinical background on the myalgia of the mastation and axillary muscles. I'll let you just... So pretty much the same thing. So I don't need to say anything? You're good? Okay, he'll defer and let us go straight into the tabular modifications. But I do want to make one comment. If you could please, I just noticed this when we were up here earlier, there's a correction in the middle paragraph there, that last sentence. That should have been deleted. It's still in your topic package, so if you could just put a line straight through that, I would appreciate it. What does it read? It's the second paragraph, last sentence. It says the differential diagnosis includes a variety of both malignant and non-malignant conditions. Just strike through it. It should have been removed. Okay, so for tabular modifications, add category M79, other and unspecified soft tissue disorders not elsewhere classified. Creating a new code, M79.10 for myalgia, unspecified site. A new subcategory, M79.11, myalgia of mastication muscle. That is going to be proposed to be broken out even further to capture the masseter muscles, right, left, bilateral, and unspecified. Additional breakout requests, new subcategory M79.11B for myalgia of the temporalis muscle, again with the further breakout for the laterality. And you will see additional new subcategories being proposed at M79.11C for myalgia of medial pterygoid muscle, also at M79.11D for myalgia of the lateral pterygoid muscle. A new subcategory, M79.12, for myalgia of axillary muscles, head and neck. This would be a further breakout, capturing additional axillary muscles. New subcategory being proposed at M79.12A. New subcategory at M79.12B. And a new subcategory at M79.12C. And a new code M79.19 for myalgia other site. I see we have someone at the mic, so I will go ahead and open the floor for questions and comments.
Jean Yoder, Defense Health Agency. I'm looking at this, and I'm a data analyst, and I have hospital commanders come and dental clinic people, though they don't use diagnoses all that much, but whatever. Okay, and they say, so what are the 100 top most common things that we have problems with? Because that's what I'm going to get my folks training on, and that's what I'm going to get all the equipment for, and whatever. And when you do something like this, you have just diluted everything that you do, and you are never going to get any money for any of your programs. Okay, I'm just letting you know the way it goes, okay? Because what's popular is what gets funded. And we have a lot of muscles in the body, and these are not the only ones. And there's a reason why we don't have them all split out like this. Because, you know, back pain, we have lots of money for back pain. We have lots of money for, you know, brain injury. We have lots of money for various things that Congress finds very important. And I look at this, and I'm thinking of all those basketball players who have those trapezius problems, and all of the folks who have those sternocleidomastoid problems. And, you know, we collect that people come in and they have pain, but we don't necessarily collect the specific muscle. And I'm saying that I don't know that I have ever seen right trapezius myalgia documented in any of my outpatient records. You know, I see shoulder pain, I see all kinds of things, but, and so when I see this and I think about the coder has to see it and the coder has to document it, and sometimes the tech has to type it into the electronic health system, and I don't know if they can even spell those things. I don't know if this is really a good way to go. Just a suggestion.
Okay, thank you. Thank you.
Lynn Keene, Keene Consulting. I think there's two important things that are missing here off this list. Because, as Jean said, I don't know we're going to get this specificity, and I don't see codes for myalgia of unspecified mastication muscle and myalgia of unspecified auxiliary muscle of head and neck. And without those two, you're going to get no more data because you're going to get myalgia other site and myalgia unspecified site, because that's all they'll have. So if you add those other two, at least you can narrow it down farther than it's narrowed down now.
Okay.
And then couple that with Linda's past comment about we're not going to get the detail until we have codes. Well, the codes have to follow the documentation. And you won't have any stepping stone here if you don't have those two
codes.
pieces in here.
Thank you.
Nellie Leon, Chisin American Hospital Association. I just want to say that I agree with everything that's been said about the level of detail in these codes. ICD-10 is not meant to be a terminology system where you want to label every single muscle. And I think that between this proposal and the ones that we just heard right before this, it's just way too much detail that it's never going to be used. And so just think about what happened when we were trying to those of us that were supporting ICD-10 implementation. The physicians across different specialties kept complaining that ICD-10 had too many codes for things that were not documented, that were not clinically significant, that they didn't identify in their records because they didn't think it made that much of a difference. And I think that's where Linda's question about what is the clinical need, why is it important to identify specifically right or left mandible, or every single one of these muscles. I think we need to establish that before we even consider whether you need to have codes, because if the everyday practicing physician looking at these cases, walking in the door, doesn't think that it's important enough for them to document it in the record, this is just going to clutter the system, and it's just going to add fuel to all those naysayers that were saying, too many codes.
Okay, thank you. Moderator, could you please open the lines up for any questions?
All lines are now unmuted.
Thank you. Are there any questions or comments on the line? Are there any questions?
Dr. Erica Reamer.
Okay.
Can you hear me?
Yes.
Sorry. I would like to agree with Nellie and Linda. I think that it was hard enough to get the doctors to deal with the kind of specificity we already have. I do think that this really kind of goes above and beyond. And, the data that you can collect, it's kind of garbage in, garbage out. So if people don't use it, then it's not robust and it's, not going to give you good data anyway. And I think it's going to be a hard sell to get doctors to do this. I agree with them.
Thank you. Any other questions or comments on the line? Okay, hearing none. Thank you, moderator. You can mute the lines. And at this time, I'm going to turn the podium over to Dr. Berglund. Thank you.
And next, we're going to talk about elevated lipoprotein A on page 39 in your handouts. And we do have a presenter for this topic. She's coming forward now. And she is stepping in and pinch hitting, so to speak, for another physician. And I will let you introduce yourself.
Sure,
I apologize.
No problem. I'm Dr. Engler. I'm a cardiovascular immunologist. I'm representing the Lipoprotein A Foundation, and I think a large number of patients that I have cared for and participated in my 38-year military health system career. Cardiovascular disease represents a major cause of morbidity and mortality in both men and women, with an increasing disease burden in our population. Lipid disorders are well recognized as a major risk factor for disease, but in fact, the current diagnostics and clinical care lack precision for 30% of the population, and the drugs used for treatment are not effective for that 30%, where elevated lipoprotein A is the major risk driver, rather than the popularly understood low-density lipoproteins, also known as LDL. Practically, the poor recognition of LPA elevation as a major cause of early cardiovascular disease risk in the presumed healthy and fit population, of which the military population is a particular passion for me, translates into less timely and less effective preventive care and is linked to earlier mortality. After 38 years of practice in the military, the sudden death of healthy, productive, and fit individuals never identified as having atherosclerotic disease risk still haunts me. and the fact that I was recently told that measuring Lp(a) in the clinical laboratory is still considered a research test by a local pathologist was very distressing. So I'm very honored to be here as a pinch hitter on this important topic. Elevated Lpa is a highly prevalent codominant genetic lipid disorder and risk factor for cardiovascular disease, including heart attacks, strokes, and peripheral arterial disease, as well as calcific aortic valve stenosis. Blood levels span a wide range, with median levels globally at 10 to 15 milligrams per deciliter. Elevated Lpa levels, generally listed as greater than 30 milligrams per deciliter or greater than 75 nanomoles per liter, affects about 20 to 30% of the global population and is causally linked to increased atherothrombotic events, the calcific aortic stenosis that I mentioned, and the variety of cardiovascular endpoints, heart attacks, and sudden death. High Lpa is one of the most common hereditary disorders, although many who have it have not been recognized. The science surrounding the Lpa particles, their structure, their mechanisms behind vascular endothelial disease is increasingly well understood, but still evolving as so many areas of medicine. There's individual diversity that introduces complexity and requires additional research to improve understanding of both disease risk and risk reduction. There's a lot of science, and I don't want to lengthen the presentation around this. That's fascinating for those of us who are interested. But suffice it to say, to summarize this particular paragraph, is that this is a very powerful marker and pathogenic, meaning it produces a role in the disease process as great, if not greater in some individuals, than the LDL that's so widely appreciated. Elevated LPL is silent, without signs and symptoms, and not able to be detected by history or physical examination. Elevated LPL is measured by a blood test that's relatively simple to do. And actually, I learned that patients who are struggling for recognition can pay to have it done on their own, which after decades of recognition of this risk is a sad state comment on our healthcare system. Thus far, the first sign of elevated LPL can be sudden death from myocardial infarction or stroke. The development of new, selective, and potent LPA-lowering agents provides hope for earlier treatment, leading to prevention of earlier morbidity and mortality risks. Levels of LPA may also be lowered by apheresis. Further understanding of LPA pathophysiology and its clinical importance in the treatment of CVD or cardiovascular disease may help reduce the residual risk present following current standard therapy. LPA testing is recommended for those at intermediate or high CVD risk, and particularly a strong family history, recurrent CVD, premature CVD, and those unresponsive to guideline-recommended therapies. I would add that the group that I work with at Walter Reed was able to add data to the guidelines that family history is a stronger predictor of downstream mortality than many other clinical measures. Measure of LPA levels in patients with at least this risk supported by several recent guidelines from medical societies, including the National Lipid Association, the Canadian Cardiovascular Society guidelines for the management of dyslipidemia, for the prevention of cardiovascular disease in the adult, and from the Task Force for the Management of Dyslipidemias of the European Society of Cardiology and European Atherosclerosis Society, the 2016 ESC-EAS guidelines for the management of dyslipidemia. So this is not a new concept as an important factor in our patient population, and particularly in the healthy, fit population as well. An elevated level of Lp(a) is the only identifiable risk factor in many patients with CVD, particularly if they're less than 65 years of age, reflecting its genetic contribution to this risk. In others, it compounds the risk from other risk factors. Finding a high level of Lp(a) in an asymptomatic patient would indicate the need for more aggressive treatment of other cardiovascular risk factors. To enable tracking of individuals and their families with high Lpa, the Lipoprotein A Foundation and its Scientific Advisory Board have proposed to create a specific ICD-10 CM code for elevated Lp(a) and also for the family history. The value of a specific code for elevated LPA levels includes improved precision in clinical diagnosis of preclinical disease, as well as the etiology of risk. And preclinical disease, as recognized by the CDC in recent years, is a huge burden of risk for the future. So early diagnosis and access to care when people appear fit but are on a trajectory towards disease and increased mortality is of tremendous value, not only to the individuals affected, but also to the society as a whole. It will enable clinicians to tailor preventative and treatment strategies for this risk confounder, in addition to traditional risk management, as well as providing a basis for data collection, supporting much-needed research into the CVD impact of this lipid within the complexity and diversity of lipid disorders. Thank you. Questions for me?
Do we have any clinical questions from the audience? Or let's open the phone lines in case we have clinical questions from the phone lines.
I convinced them.
That's it. You must have convinced them. Yes. Thank you so much, Dr. Engler. And thank you for being here. All right. So looking back at lipoprotein A, we're going to go next to the code section here. I will say a little bit briefly as we look at this, lipoprotein A and the problems it can cause. Briefly, to kind of reiterate, if we find out about somebody who does everything right, who has a good diet, exercises, and then we find out they still got heart disease, most of the time, if you check, the reason they got heart disease is going to be this lipoprotein A. And it does affect a huge percent of the population, millions of people. It's a complicated particle, has these two big components. One part's like LDL, that's bad cholesterol. One part's like plasminogen. Well, we just talked about plasminogen deficiency this morning, as you'll recall, and so we know plasminogen's an important thing from talking about it this morning, and it can interfere with breaking down blood clots, potentially, because of it having a part that looks like plasminogen but doesn't act like plasminogen in breaking down blood clots. It may interfere with plasminogen. So those are a couple of ways, just acting like bad cholesterol or acting in a way that interferes with breaking down blood clots are two ways that lipoprotein A may act. And one of the things that I started to have in this write-up about it that Donna made me take out was about the structure. See, the small dense forms are the bad ones, and the big ones have these loops that are called kringles. Kringles are a type of Danish pastry. And having more kringles was a good thing. Does that mean we can eat more Danish pastries? It sounded like a good thing to me, but we also talked about central obesity this morning, and I'll get myself in trouble if I go back to that. So in any case, the small dense forms of this are good. The larger forms actually, those are good. The small dense forms are worse. So there's a few different forms of lipoprotein A, and it's mostly a genetic factor as to whether you have the good type or the bad type. And it can be a problem for those who have the bad type. They're more at risk of getting heart disease and getting problems with strokes and peripheral arterial disease. So it's a real problem. Again, there's a huge percent of the population. Globally, it could be 20 to 30% of the population. The percentage in the US, it's not clear if it's exactly 20 to 30% or where in that area. But it is a significant problem. And for people who are at even intermediate risk, at least some guidelines do recommend testing for lipoprotein A. And particularly for anyone with a family history of lipoprotein A, it's very important to get that checked. So this is something that's important to look at. Looking now at the codes, we're proposing a new code at E78.4, other hyperlipidemia. We're proposing a new code, E78.41, elevated lipoprotein A. A new code is also proposed for E78.49 for other hyperlipidemia. This would include the familial combined hyperlipidemia, which is an older term not used as commonly, but a particular form that involves high triglyceride and high cholesterol both. Also at Z83, family history of other specific disorders. At the Z83.4, family history of other endocrine, nutritional, and metabolic diseases, we would propose a new subcategory, Z83.43, for family history of other disorder of lipoprotein metabolism and other lipidemias. And we would propose a new code, Z83.430, for family history of elevated lipoprotein A. This would be a good reason for you to get your own lipoprotein A level tested, of course. And then also a new code, Z83.438, for family history of other disorder of lipoprotein metabolism and other lipidemia. And this would include family history of familial combined hyperlipidemia and other things of that type. So that basically covers all of the things that we have here. And let's open the floor for comments and questions. Please identify yourselves, please.
I'm Sandra Tremulous with the Lipoprotein A Foundation. To help identify asymptomatic patients with high LPA, the Lipoprotein A Foundation and its Scientific Advisory Board have proposed this new code, and thank you for letting us present this proposal for elevated lipoprotein A. This will enable clinicians to more easily convey its link to cardiovascular disease risk and to tailor prevention and treatment strategies. Thank you very much.
Thank you.
Nellie Leon, she's saying American Hospital Association. Question for the sake of symmetry, since this is identified through a blood test, several of these other conditions that are in these categories, you have the ending emia, like lipidemia, hyperlipidemia. Is it ever get referred to as elevated lipoproteinemia, or do you just not use that terminology at all?
Hyperlipoproteinemia A would be a term that might be seen, but it wouldn't be as likely to be seen. They usually would just say elevated.
Okay, that's
fine. We did talk about that, and that's an excellent question, certainly. But the way it is usually referred to is as elevated lipoprotein A, and it's with the parentheses little a, which tends to look a little
It looks a little odd if we don't know. And I guess then my follow-up question then is, it's typically documented as the acronym, like we have it on the proposal. Is it like LP parens small a?
Yes.
Because if that's the case, then it may be helpful to have it as an inclusion term.
Have an inclusion term as, sorry, what?
The abbreviation.
The L and the P and then the parentheses little a. That could be a thought because it is often abbreviated that way, yes.
Okay.
And Sandra Tremulous, when she would talk to me about it, would always say lipoprotein little a, to be very clear. So just to be very clear that this was the little a and not to confuse it with any other sorts of things. But
yes, then maybe it's a typo, it's an S instead of an A or something like that. But I'm just being funny. But I think that the inclusion term that matches what the clinicians use would be helpful.
Yeah, and that probably would be the way it would be documented because it is the way it's usually discussed. I suspect the labs would generally report it and may use something that looks like that also. So, yes.
Hi, Jean Yoder, contractor for the Defense Health Agency. Is this, once you find it, does it ever go away, or do you always have it? Okay, because if you always have it, then
Yes.
I can understand why it would be here, because if it was something that could be transient, then I would have thought that it would be back in the abnormal findings, in the lab findings. But, so this is a permanent diagnosis, it doesn't go away. Never mind, I'll go sit down.
Does it go away? Don't we wish for anyone who has it, I think, yes. But no, it doesn't go away, and diet and exercise doesn't make the risk go away. Certainly diet and exercise can help other risks to be lower, and in that respect, it is good to have the diet and exercise still, just to clarify. But yeah.
I just wanted
Linda.
to second what Nellie and Jean said, that usually when you see a diagnostic phrase, elevated something, you think it should be back in the symptom chapter, right? But as Nellie pointed out, this is what this is referred to. This is not a finding. This is a diagnosis.
Yeah, this is a diagnosis,
okay,
exactly.
So
yes.
I think we need to
Dr. Engler, did you want to address?
Yeah.
Sure. That way people who are listening
People
can also
think I
hear.
won't yield
Sorry.
the mic, but I will.
Now, unlike the other lipid tests, this does not have to be done fasting. So you can, that's why it is a genetically defined presence of an elevated lipid protein that carries with it that heightened risk. And the future, you're going to see people, and what right now the struggle is it only 20, 30% or is it more? Because there is a linear response to the level in terms of risk. And if you also have LDL, the traditional elevations that are more diet and exercise dependent, that accelerates your mortality curve. So it is a very important, and we have a huge challenge in educating the healthcare system to take this seriously. And to not, when people are fit and not obese, nobody pays any attention to lifestyle. And we should be starting to pay attention in adolescents and young adults early on. So it's a very important thing to make highlighted as an actionable, even if there isn't a drug necessarily.
Right. I think, thank you for clarifying that. I think the general thought here is that it's worth identifying in the system. It's just a question of where we would put it. So if you, like what chapter we would put it in ICD-10, and if this is a finding, just a finding, then it goes back in the symptom chapter. But from what I'm hearing, this isn't a finding, this is an actual diagnosis. It doesn't happen to use the word emia or use the phrase emia at the end, but this is a diagnosis that somebody will have for their whole life. So yes, it does belong here in E784.
And as another aside, I will say many of you know Dr. Linzer and people at the American Academy of Pediatrics who work closely with. And we did ask for input from them, and they did weigh in and say that this did look like the appropriate place to put it also, and they did seem to be in favor of it in initial preliminary comments anyway. So just for additional clinical support on that line. And since Dr. Linzer's not here today, you can verify with him tomorrow. He should be here tomorrow, and you can confirm that with him, of course, then. But he's usually very good at speaking for himself when he's here, of course. But yes. So in any case, this does look appropriate. Now, I already had mentioned, first, everybody does make lipoprotein A, so it's not something that's just missing entirely. But some people make smaller, denser forms of it, and other people make larger, longer chain, so to speak, forms of it. And those who make the smaller, denser forms generally are more likely to make more of it, and that is then something that puts them at risk, is my understanding at least. So basically, to summarize briefly, and again, your risk related to this is basically entirely genetic, again, to re-summarize. So that covers it. Any further questions here or any questions on the phone? Hearing none and seeing none, I think we can safely move on to our next topic. And I will pass the podium over to Cheryl Bullock now.
I'm waiting for my presenter here. The next several topics that will be presented is in relation to mental health diagnoses. I have one, and Dr. First will be presenting the remaining 3, and he also has slides to be presented as well. But let me do the initial one. The first one I'm going to deal with is postpartum depression and postpartum psychosis. And it can be found on page 72 of your topic package. Postpartum depression, PPD, typically emerges over the first 2 to 3 postpartum months, but may occur anytime after delivery. A few symptoms of postpartum depression include depressed or sad mood, tearfulness, loss of interest, and change in appetite or suicidal thoughts. Significant anxiety symptoms may occur, and it may be difficult sometimes to detect postpartum depression because many of the symptoms also relate with just regular depression. Postpartum psychosis is the most severe form of postpartum psychiatric illness. It is very rare, and it occurs in approximately 1 to 2 per 1,000 women after childbirth. Its presentation is often very dramatic, with onset of symptoms as early as 48 to 72 hours after delivery. Clinically, these two conditions have significant different presentations and treatment guidelines. Currently, in ICD-10 CM, both of the conditions are found in the same code. It is being proposed to revise the current code title and specific codes for the clinical conditions. The American Psychiatric Association, APA, has reviewed and support this proposal. Our proposed tabular modifications. We're proposing to revise the title of F53 from puerperal psychosis to mental and behavioral disorders associated with the puerperium not elsewhere classified. It is also being proposed to revise the excludes note from an excludes 1 to an excludes 2. 2 new codes are being proposed. New code F53.0, postpartum depression, with inclusion terms of postpartum depression NOS, postnatal depression NOS. The additional new code of F53.1, puerperal psychosis, with inclusion term of postpartum psychosis or puerperal psychosis NOS. Open floor for comment or questions. No? You good? Okay. Moderator, could you open the phone lines, please, for any comments as well?
All lines are unmuted.
Okay. Not hearing anything on the moderator, you could close the phone lines. And we're moving on to the additional mental health proposals. Okay, not quite yet.
Jean Yoder, Contractor Defense Health Agency. Are we going to need any kind of a note in the 09A, whatever back there with the mental health in the obstetrical area? Do we need some kind of a excludes or something to get people back here?
Okay.
Okay.
And I
sorry.
think you're right. That did come up in conversation when we were reviewing it, excludes note at O. Okay, on to the next group of proposals. And my presenter that I have up here is Dr. Michael First. He is a consultant with DSM-5, editorial and coding consultant, and a professor of clinical psychiatry at Columbia University. I think we'll start out with the cannabis.
Sure. That's the wrong slide.
That's not us. There, right there.
Okay, good afternoon. First presentation is about a request for a new code for cannabis withdrawal. This is being, again, this request is being made by the American Psychiatric Association. Is this supposed to work?
David? This one.
Oh, this one, I'm
Point
sorry.
that way. and
Okay.
it's fixed that way.
Okay. That's okay, I can do it. Okay, so the background is that we're requesting a new code for cannabis withdrawal. As you're probably aware, in the F1 section, in the mental disorder section, there are a bunch of codes for withdrawal from a number of different substances. So there exists now specific codes for alcohol withdrawal, opioid withdrawal, sedative, hypnotic, and anxiolytic withdrawal, cocaine withdrawal, other stimulant withdrawal, and nicotine withdrawal. However, no such specific code exists for withdrawal from cannabis. So the reason for that was at the time that the ICD-10-CM was being developed in the late 1990s, cannabis withdrawal at that point was really not recognized as a clinically significant syndrome. However, research on cannabis withdrawal, which has been conducted over the last 10 years, has clarified and supported the distinct nature and the clinical importance of cannabis withdrawal, resulting in the inclusion of cannabis withdrawal as a disorder in the DSM-5. So this was added to DSM-5 in 2013. So essentially what we're asking is for the ICD-10-CM to catch up with what has already been added to the DSM-5. So it turns out that cannabis withdrawal is relatively common among those with cannabis dependence, and persons with cannabis dependence comprise a substantial portion of treatment admissions for substance use disorders. This is clearly a very clinically important problem. So we're requesting a distinct code with the hope that it will increase public awareness of this disorder and perhaps leads to an increased treatment seeking for those experiencing cannabis dependence. So what does cannabis withdrawal look like? It's characterized by symptoms such as irritability, anger or aggression, nervousness or anxiety, sleep difficulty, decreased appetite or weight loss, restlessness, depressed mood, and physical symptoms such as abdominal pain, shakiness and tremors, sweating, fever, chills, or headache, all that develop within a week of stopping cannabis use that has been heavy and prolonged. So since the ICD-10-CM substance use disorder codes depend on whether or not withdrawal is occurring in the context of cannabis dependence, we're actually requesting two codes for cannabis withdrawal. F12.23 is for cases of withdrawal that are occurring in someone with cannabis dependence. We're also requesting F12.93 for cases of physiological withdrawal from cannabis occurring in a person who is regularly taking cannabis in a context other than cannabis dependence. So for example, someone who's actually taking cannabis under medical supervision, medical marijuana is becoming pretty popular, those people could develop cannabis withdrawal if they suddenly stop it. So that person would get 12.93 because that person has a physiological withdrawal, not in the context of cannabis dependence. When we talk about cannabis dependence, we consider that a mental disorder where the person's control of cannabis is out of control. If somebody is taking it under medical supervision, then the context of the withdrawal would not be in dependence. So it's really and you can see here from the actual code changes. So this is in the F12 cannabis-related disorder grouping, and the new code fits in right after cannabis dependence with intoxication. There is no F12.23 in ICD-10-CM, and the .23 is the code that's used for dependence with withdrawal for all the other substances. So this is in keeping with the normal rule of having the code, having the third digit indicate the type of substance. And you can see we're obviously deleting cannabis. So cannabis withdrawal was an inclusion term under F12.288. So we're really basically pulling cannabis withdrawal from that code and giving it its own separate code. Now, for those people who are having withdrawal from cannabis not in the context of cannabis dependence, that belongs to the F12.9 cannabis use unspecified. So the new code there will be F12.93, cannabis use unspecified with withdrawal. And that is similar to other drug use with withdrawal codes which are already in there for other substances. So I guess I will open it up to any questions. Do you want to?
Do we have any questions for Dr. First?
Yes, can we go back to one of the slides? Slide 5. Just want to be sure I understand this.
That seems to go off. Slide 5. Is this slide 5?
No, previous. Thank you, okay.
That one, okay.
So we would have the F1223 for dependence for people who are using...
For people who develop withdrawal in the
withdrawal.
context of cannabis dependence.
Where'd this go?
Where did it go?
David, are you controlling it now?
No. Yeah,
Okay, let me move up again. Okay,
There we
so
go.
Thank you.
Yes.
there it is.
I made it full screen.
Okay, great. Yeah, so F12.23, remember the way the coding works for all of the substance codes combines the pattern of use, which is dependence,
Yes, I know.
abuse, or unspecified, with the actual effect. So withdrawal has to be paired with either dependence. It's not paired with abuse because the idea is withdrawal would only occur in the context of dependence, but the other context that it could occur in is other use of cannabis that doesn't meet the definition for dependence. And the best example, a good example would be use under medical supervision. So that's why we need the F12.93 for those cases and F12.23 for the cases where it occurs in the context of cannabis dependence.
Yes. So my question is, seeing your note about F1293, if someone is taking medical marijuana, are they not dependent? I mean, when we talk about someone taking methadone, which is medically supervised, that person is dependent on methadone?
Well, we've been trying to make the distinction in the DSM between physiological. So the part of the problem is the use of terminology. As you're probably aware, in the DSM-5, we've actually no longer used the word dependence. We call it cannabis use disorder, mild, moderate, severe is what's currently in the DSM-5. One of the rationales for that change is the confusion about the word dependence. Physiological dependence is when your body literally, if you stop a drug, you develop a withdrawal, which is a physiological response. Dependence in the context of the DSM is a psychological condition where you've lost control of your ability to regulate your use of a drug. So so we consider dependence with a capital D, or cannabis dependence, as a mental syndrome that really reflects the idea that you've lost control over your ability to use cannabis. It's dominating your life. But we're saying that you could develop physiological dependence without having capital D dependence. And a good example of that is someone who's prescribed pain medication by a doctor who's taking a high dose of Vicodin, and goes away on vacation and doesn't have their medicine. They'll develop withdrawal, but they don't have opioid dependence from a DSM perspective. What they do have is physiological dependence on opioids. So we're splitting the idea. So the F12.2 category is for mental disorder dependence, and the F12.9 is really for physiological dependence. We are making that distinction, which matches what you see in real life, that there are people who develop physiological dependence without having psychological dependence.
Yes.
Does that make sense?
It does. My point here is not that we don't need codes. I support having these codes. My concern is that the way that the codes are defined, and given what you've written on the slide, I don't necessarily think that you will get this distinction in the data. That's my concern. So we're either going to need some incredibly specific article in Coding Clinic, or some other way to say that if someone is using medical marijuana, that it's always F12.93. That's correct?
Yes.
It would always be F12.93. And if someone is using marijuana recreationally or, illegally, then that would be the F12.23. But there are other situations, I assume, where, or perhaps there aren't. Can someone who is using marijuana recreationally also develop withdrawal? Or is that always going to be, also develop physiologic withdrawal, or is that always going to be somebody who would be considered dependent, even if it's just somebody who smokes a lot of joints at a Jimmy Buffett concert and the next morning feels terrible?
No, and that's because the concept, we have this idea of cannabis dependence, which is a psychological condition where you can't control it. And then there are people who just smoke a lot of marijuana, often enough that they could develop a physiological dependence and withdrawal. So that's why it's cannabis use unspecified. It says the person is using cannabis, it's not dependence, which is already there, and it's not abuse, it's this other category. For people who select their codes via the DSM-5, it's, people, because the DSM-5 is this whole complicated book with very specific rules. This
Unlike
distinction,
ICD-10, for example.
Well, ICD-10 is right, but the rules actually clarify this point. I mean, so from a coding clinic perspective, I agree that this distinction is not obvious within the ICD-10 CM. It is within the DSM.
Right,
so it might be helpful in coding clinic to clarify that the fundamental distinction between F12.23 and F12.93 is whether one considers the pattern of use severe enough to qualify for an out-of-control use of cannabis rather than just a lot of cannabis.
Actually, that's not quite where I'm going with this, because the coder is not going to know that,
right,
and the physician is not going to write that. The physician's not going to say physiologic withdrawal or something like that. We need to know based on how the codes are defined. And again, I don't object to creating codes. I just want to be sure that they're genuinely useful and that they're used consistently. We need to know, first, F1293 is always used for someone who's under medical supervision.
No. That was an example. I guess the way we were viewing it is, if somebody writes down on the chart...
I'm here at this meeting, and I don't understand what you're trying to get across. And I've been a coder for 34 years.
Okay,
I'm suggesting that you take me seriously.
No, I'm taking it serious. I guess when I'm cannabis use unspecified, if somebody writes down cannabis withdrawal on the chart and no other information, it would have to be 12.93 because there's no statement of whether or not the person is using cannabis.
I understand that. So the question is, if someone is known to be taking marijuana for medical reasons, and I'm sorry, I don't mean to belabor the point, but I don't see a point in creating codes where it's not clear how to use them. So if someone is known to be using marijuana under a medical protocol, and that person has withdrawal, will that situation always be coded to F1293? There may be others that go to F1293, but if someone is taking medical marijuana and has withdrawal, will that always go to F1293? It would never go to F1223.
Assuming they're actually doing it. I mean, one of the problems, as you probably know, with medical marijuana is people often use that as a label to be recreational use. So if medical supervision means using it as directed by a physician, then that would always be 12.93. If somebody is getting a medical prescription for marijuana and then on their own using 5 times more than they were told, that could be F12.23. Because for that person, their use pattern is exceeding medical use and probably would qualify for dependence.
Yeah, I'm sure you're sick of hearing from me, so I'll just turn it over to my friend Sue.
Sue Bowman with the American Health Information Management Association, and I completely agree with Linda, and I'm not going to try to restate all of her excellent points, but I see the distinction you're trying to make on the slide here. I'm concerned, as I believe Linda is, that this distinction on a day-to-day coding level is going to be a lot tougher. And we've just got, we've been explaining in coding clinic and elsewhere, well, if you have withdrawal, then you have to be dependent in order to have withdrawal. And now we're saying, well, not in this case, because now we have a withdrawal code that isn't under the dependence category. So I think there's going to be a lot of confusion about when to use one versus the other and what needs to be documented to use it, and what the distinction in the medical record documentation would be in order to use the codes appropriately. Otherwise, I think, as Linda said, the data is just going to be terrible, with both categories of patients somehow ending up in both 23 and 93, depending on how it happens to be documented.
I understand what you're saying. I guess all I would say is that we're following a pattern that was already in ICD-10 CM for opioid withdrawal, for sedative withdrawal, and for amphetamine withdrawal. All of those currently in ICD-10-CM have a 23 and a 93, and that was the intended distinction when that was put in. We're simply following the same model that was already there for those three drugs. So that concern you're raising actually applies to those three other conditions as well. So, I mean, I guess we have a history of whether or not there is a problem, but the same distinction. If somebody is using pain medication and goes into withdrawal, the coder has to decide whether it's F11.23 or F11.93, because both of those codes are currently in ICD-10-CM. I agree it could be a challenge from just looking at a medical record, which of the two to use. Presumably, the clinician would write down opioid dependence and opioid withdrawal to give you a clue that it should have been F11.23 as opposed to 11.93, and that would be the case here too. Presumably, the person would write down two codes. Write down on the chart, cannabis dependence and cannabis withdrawal. If you write both of those down, it would be F12.23. If they just write down cannabis withdrawal and there's nothing else on the chart to indicate that the person has a drug problem with cannabis except for withdrawal, then that would be 12.93. But we're just following a convention which is already in ICD-10-CM for other prescribed drugs which can be abused.
I'm Nellie Leon Chisin, and I'm the editor of Coding Clinic. And so for every fourth quarter issue, when new codes come into place, we are primarily responsible for trying to kind of explain why these codes were created and how to use them. And I have to say, like Linda and Sue, I'm kind of listening to you and thinking, gosh, you think this will be explained in Coding Clinic? I don't know how I would explain it. Because I thought I understood it when Linda was trying to say, okay, so someone getting medical marijuana having withdrawal symptoms, you would be at F1293. I don't get that from just looking at the tabular instructions, but I'll take your word. But then you had these additional caveats that I thought, oh, how is the coder going to figure that out, and how do we explain to the coders what they're able to do versus what you as a physician would understand automatically because of the DSM criteria, which we as coders do not have access to, nor are we allowed to apply them because we're not physicians.
So would not an adequate explanation to say that if cannabis dependence is not documented, then you should be using F12.93, and otherwise, if it is documented, then it's F12.23?
Okay, so you're saying that the doctor has to document dependence, because I think
Yes.
that part of this narrative under F1293 that you have as your example made it sound as if it's under medical supervision, the doctor doesn't have to write dependence, or even if they do, you're going to be at F1293. Because I think that this distinction of dependence with a capital D, as you were saying, that we don't see on the records. We don't distinguish it in the classification where we've sort of said dependence is dependence. We don't make a distinction between psychological versus physiological. And, I don't know if you want to sort of consider, I know not right now because this is just following a pattern of what you have already in the classification. But if that's what you really intended, then maybe the term physiological has to be introduced somewhere on all these other codes that exist, because I think that creates a problem. And I'm not trying to be funny or anything like that, but we get a lot of questions from coders having trouble understanding, when do I use dependence, if the doctor writes withdrawal, but they don't write dependence, what do I do? So these are very real problems. I think that, and Sue knows about those as well, because she gets them, I get them, because they figure, well, maybe one of the two of us can help explain it. So, and I don't mean to just focus on only marijuana use, but I think that to the lay person, this is how the questions were coming to us, people were thinking that there was a distinction based on, is it legal use, where you got a doctor's prescription, versus recreational use. And you're absolutely right. Sometimes they will say medical use, but then they're using more than what the physician ordered.
No, I agree. I was trying to give, I see you're right. In a way, this example of medical marijuana was trying to explain how it would be. But I think technically you're right. I think from a coding perspective, unless dependence is documented, it would make sense to use cannabis, because in fact it's really a literal thing, cannabis use unspecified with withdrawal. If the fact that they're dependent isn't noted, then the use is unspecified. You should really only write down cannabis dependence with withdrawal, which is F12.23, if the physician has written down on the chart cannabis dependence. So in a way, the rule is very straightforward. I think maybe I mucked things up by putting that example of medical marijuana. I really meant that if it's not dependence, then it's this use unspecified, and one of the more common scenarios where that would happen would be this medical supervision, but that's not required.
Okay, and then this other question that I have, and I'm not sure if you're able to answer this. Non-psychiatrists, they also use the word dependence in their documentation. Do they use it in the same context that you do, the DSM definition? Or when they use the word dependence, they don't make a distinction between physiological and psychological dependence?
It's a good question. I think for cannabis dependence is probably a term that's people are less familiar with dependence on cannabis, but opioid dependence, I suspect that a non-psychiatric general practitioner, when they use opioid dependent, they're probably are using it interchangeably. Either anyone who goes into withdrawal could be called dependent, or the person who is a heroin addict and ruins their life would be called dependent, and they use the same word. But they're, as you can see from the way I'm explaining it, they're really different medical concepts. The difference between using something as prescribed and being physiologically dependent. We just don't have the language to, because ICD-10 has used the word dependence, the DSM tried to solve that problem by banishing the word dependence, precisely for this reason, because of this confusion. But we can't get rid of the word in the ICD-10 because it's already there, and it comes from the WHO. So I'm not sure, that there is a difference between the two concepts, and there is potential confusion because I suspect in most cases when people use the word dependence, it is used properly. There's these scenarios where people are almost invariably, when it's a prescribed medication used as directed, those are the most common examples where you would see physiological dependence in the absence of, capital D dependence. The two almost always go together. If you're alcohol dependent, you're going to be physiologically dependent, you're also going to be an alcoholic. The only cases where they become separate is when somebody is using it prescribed, so you could develop physiological dependence, but not capital D dependence because the person's simply following a prescription. So that's the most common. So I think that concept is well established. And in most cases, when somebody writes down dependence, it's usually going to be both physiological dependence and capital D dependence at the same time. And so it's only a big exception is the medical use. Prescribed use is the case where there's a divergence between physiological dependence and capital D dependence.
Right, thank you.
Stay right here. Moderator, could you open the phone lines and see if there's any additional comments or questions, please?
All lines are unmuted. Hi, this is Dr.
Go ahead.
This is Dr. Erica Reamer. So I agree with Nellie, and I feel philosophically that if we're making changes, that this is the time to be putting clarity in rather than hoping that Coding Clinic will fix it on the back end. So I guess one of the first questions to ask is maybe you can put as an inclusion term includes medical marijuana use in the cannabis use unspecified, and maybe that way people will know to go there. Yeah. And the other thing is, you were asking before whether people could just be using cannabis and not be dependent, and the answer is absolutely. So the first-time user can come in with F1292, cannabis use unspecified with intoxication, and they're not considered dependent. I do think that it should be, we should really be clear that a lot of physicians don't know the difference between use and dependence, even before the fact that now we really use use disorder according to DSM-5.
I agree. This has been a problem. The DSM had tried this issue of the difference between use and dependence and abuse. These colloquially are used in such a way, it is very confusing. And the DSM has tried to be very precise. I agree there's a potential problem, and I mean, another thing is putting an exclusion term under cannabis use unspecified with dependence. Maybe that's given because it's obvious you're not supposed to use the unspecified if dependence is there. But that's really, if dependence has been documented, you use F12.23. If it's not documented, it's F12.93. And you could put medical marijuana as an inclusion just to clarify that this is one way that could happen.
I actually have a comment for Dr. Reamer, if she's still on the phone, and also for our speaker. That's one of the things that I was trying to get at. If F12.93 would always be used for someone who is taking cannabis for medical reasons, has a prescription. But
if they're going in withdrawal, most people who use it for prescription, I think, would not go into withdrawal, because that's part of the problem is that in order to go into withdrawal, you have to have a pretty heavy and prolonged use. I suspect that if people use low doses of cannabis prescribed, you probably wouldn't get withdrawal anyway. So it's a very high dose use prescribed or directed that would get it. So I think the number of cases of F12.93 will be low for that reason.
That's not where I was going with this. What I'm trying to say is that Dr. Reamer suggested that and you concurred, that we put medical marijuana use as an inclusion term under F1293. If we do that, that means that anyone who has some kind of withdrawal, any kind of withdrawal, and has a prescription for marijuana use will be coded to F1293. My understanding, though, is that you felt that was not appropriate, that such a person could be appropriately in F1223 if they have a prescription but they're supplementing it at the Jimmy Buffett concert. Is that correct?
Well, for somebody using it just recreationally, sporadically, wouldn't develop withdrawal anyway because they wouldn't be using it enough. But the point I was making is, it is the possibility that somebody's getting it under the guise of medical and is actually using it enough that they could develop, use it and going to different doctors, for example. Let's say they go to different clinics with different prescriptions. That person, even though it looks like it's under medical supervision, in fact has capital D dependence. So
let's put it this way. If we can put a note under F1293 that says, medical supervision. What that means in practice is that anyone who comes in with any kind of withdrawal and has a prescription, a withdrawal from marijuana, and has a prescription for medical marijuana, 100% of the time will be coded to F1293. If that's acceptable to you, then that's fine.
Okay.
Dr. Reamer, did you have any more comments?
Well, I do understand where Linda is coming from, and I kind of agree with her. I think that there are people who have medical marijuana prescribed who may end up overusing it for whatever reason and really end up being dependent under the old terminology of what dependence is. So they really would end up falling into F1223, and I think that there is going to be some confusion, but I'm not sure that this is worth dying on our sword for, I guess.
Okay, again, I appreciate the dialogue that's been going on, and we will continue to work with Dr. First, as well as looking forward to any comments to give us other things to consider when we take a look, when we revisit this proposal. The next hot topic for under the psychiatry will be the Factitious Disorder. This is a representation as well. It can be found on page 44 of your topic packet. And Dr. First.
Okay, you have the getting the presentation.
Operator, could you mute the telephone lines, please?
Okay, this is a representation of a proposal that was presented. There we go. Of a proposal that was presented at the March 2017 meeting. So let me start again. What was the proposal from a clinical perspective, and then we'll talk about the current incarnation of it. So first of all, the concept of factitious disorder is a condition, a psychiatric condition that involves the falsification of medical or psychological signs and symptoms or the induction of injury or disease associated with identified deception. So this person is deceiving whoever they're presenting to, making it look like they have a condition that they really don't. The current coding in the ICD-10-CM is subtyped based upon the DSM-4 subtyping, which was based on the type of symptoms. So the current coding is F68.11 for physiological symptoms, F68.12 for psychological symptoms, and F68.13 if the person is presenting with a mix of psychological and physiological symptoms. That distinction, when it was put into the DSM-4 in 1992, it was felt at that time that that was an important distinction. But over the last 20 years, whether it's psychological or physical or both really is not clinically that meaningful. So DSM-5 subtypes it using a different approach, which is a much more clinically meaningful thing, which is whether or not the factitious disorder is imposed on the person is doing it to themselves, presenting with the psychological or physical symptoms, or whether it's imposed on someone else. This is the condition that's often called factitious disorder by proxy or Munchausen's by proxy. This is a condition, typically, it's a parent creating an illness in a dependent child. And that right now is not indicated at all in the current system. Just and as a clarification, one confusion in the terminology for factitious disorder by proxy is who gets the diagnosis. Even though the child is brought into the emergency room with a bleeding disorder, the patient and the identified person that gets the diagnosis is the mother or other person who's inducing it in the child. And that's one of the reasons the terminology has been shifted between imposed on self as opposed to imposed on another to make it clear that the diagnosis of factitious disorder goes to the perpetrator of this abuse, not to the victim, which is the child. The child would get an abuse code. So we had requested actually twice, in September of 2016 and March of 2017, a change in the coding to reflect this imposed on self and imposed on another. But in response to the original comments that we received based upon this proposal, there were some concerns about the fact that we were changing the meaning of existing codes. So the current proposal is a proposal to add a new code for factitious disorder imposed on another without changing the meaning of the existing F68.10 and .11 codes. So this is the proposal. So F68.1, which is factitious disorder, which is the main category, it has three subtypes now in ICD-10-CM. F68.10 is unspecified. 1.1 is with predominantly psychological symptoms. F1.2 is predominantly physical signs and symptoms, and F1.3 was with predominantly psychological and physical signs and symptoms. So the way we've modified it, we're asking for those four codes to be revised to clarify that they refer to factitious disorder imposed on self, which is by far the most common presentation of factitious disorder. This new code for factitious disorder imposed on another, we're now requesting a separate new code that was not in the ICD-10-CM before, which is F68.2, to be called factitious disorder imposed on another, with two inclusion terms, Munchausen syndrome by proxy and factitious disorder by proxy. So this achieves what we are hoping, was to have a new specific code for this factitious disorder imposed on another while maintaining the existing specification and simply clarifying that the F68.1 category is factitious disorder imposed on self.
Any questions for Dr. First? Not seeing any. Moderator, could you open the phone lines, please?
All lines are unmuted.
Are there any comments or questions for?
Very open-minded.
Okay. Not hearing anything directed to the proposal. Moderator, you can mute the phone lines, please. And we will continue on with our next proposal. Dr. First. This is on the Obsessive-Compulsive Disorder, and it is found on page 60 of your topic package.
Okay, great. So this is a proposal for changes to the F42 category, which is obsessive-compulsive disorder. So in summary, what we're proposing here is we're requesting that the fourth character for code category F42, which right now F42 has been split into the following fourth-digit categories: F42.2 for mixed obsessional thoughts and acts, F42.3 for hoarding disorder, F42.4 for excoriation disorder, F42.8 for other obsessive-compulsive disorder, and F42.9 for it should be obsessive-compulsive disorder unspecified. These were implemented on October 1st, 2016 at APA's request. We're requesting that these fourth-digit codes be removed and that the category go back to F42 for obsessive-compulsive disorder, and that the hoarding disorder and excoriation disorder, which was the original reason for the original request for F42 changes, be assigned separate codes: F48.3 for hoarding disorder and F63.4 for excoriation disorder. So let me explain the history of this. So if you go to the WHO ICD-10, the F42 category has, the fourth digits have a different meaning. There are three subcategories for F42 which indicate the predominant type of symptom of the obsessive-compulsive disorder. F42.0 is for predominantly obsessional thoughts, ruminations. F42.1 was for predominantly compulsive acts, and F42.2 is for mixed obsessional thoughts and acts. And it is the case that people with obsessive-compulsive disorder, while most of them have both obsessions and compulsions, there are people who have just obsessions and other people who have just compulsions. So this is what the WHO had originally implemented in the original ICD-10. But when the ICD-10-CM was being developed in the 1990s, these three subtypes were not implemented in ICD-10-CM, and there was just a single category for obsessive-compulsive disorder, and that was F42. And the reason they weren't implemented is that it was felt that what type of symptom predominated was not something that clinicians ever wrote down on the chart. It was really not meaningful, and that people just usually write down obsessive-compulsive disorder, so the F42 would be the proper category. Now, right after, when ICD-10-CM, the freeze was lifted, the American Psychiatric Association made a number of proposals to create new codes for categories that had been added to DSM-5 but were not in ICD-10-CM. In particular, two disorders that had been added to DSM-5 that had never been in the DSM before were hoarding disorder and excoriation disorder. So this initial proposal was to add a fourth character to obsessive-compulsive disorder, F42.3 for hoarding disorder and F42.4 for excoriation disorder, and we asked for a reactivation of the original WHO ICD-10 code of F42.2 for mixed obsessional thoughts and actions. So that was the original idea. The problem, however, which was pointed out after this was implemented, there were kind of two basic problems. The first problem is the fact that hoarding disorder and excoriation disorder are not actually subtypes of obsessive-compulsive disorder. They are distinct conditions. They are related in some way to obsessive-compulsive disorder, but it didn't really make sense to have them as subcodes under obsessive-compulsive disorder. The second problem was the use of F42.2 for obsessive-compulsive disorder also didn't make sense because there are individuals that have obsessive-compulsive disorder with just obsessions or compulsions. So this was sort of brought to our attention after this change was made. So what we're really, so then we were made aware of this back in September of 2016. So we actually made a proposal to fix this, and it was presented I presented it at the September 2016 meeting. And what the proposal was going to do was to make this look like the way DSM-5 was. We had originally asked that F42, which is now obsessive-compulsive disorder, be changed to be a diagnostic grouping called obsessive-compulsive and related disorders. That's what the DSM has. And that grouping in the DSM-5 includes obsessive-compulsive disorder, body dysmorphic disorder, hoarding disorder, trichotillomania, and excoriation disorder. So we thought that if F42 were renamed obsessive-compulsive and related disorder, and F42.2 was renamed obsessive-compulsive disorder, then the whole thing would make sense. Because in fact, it is the case that hoarding disorder and excoriation disorder are subcodes of the general grouping of obsessive-compulsive and related disorders. The problem, however, was after we made this proposal, it was rejected internally because we found out it was not kosher to rename F42 from obsessive-compulsive disorder to obsessive-compulsive and related disorder. So we basically had to go back to the drawing board, and what you're seeing today is our back to the drawing board solution to the problem of having separate codes for hoarding disorder and excoriation disorder. So this is the proposal. This is the proposal that we had made back in September 2016. As you can see, it was our attempt to rename F42 and have hoarding disorder and excoriation disorder go under that category. As far as today's proposal, we're now requesting to put F42 back to the way it was. So it will just be obsessive-compulsive disorder, and we're going to request new codes and other sections to cover hoarding disorder and excoriation disorder. So, and this was the rationale for the codes, the places for where we asked them to be put into ICD-10-CM. So trichotillomania is currently in ICD-10-CM, and it's hair pulling disorder, and it's given the code of F63.3. Excoriation disorder is skin picking disorder. Those two conditions are very, very similar. The difference is basically whether you're pulling hair out or picking the skin. But they're conceptually the same type of disorder, so we felt that it made sense that the coding for excoriation disorder be placed adjacent to trichotillomania, and that's why we've requested a code of F63.4. Hoarding disorder, however, was a bigger challenge. It was clearly not obvious where to put hoarding disorder. It's sort of similar to obsessive-compulsive disorder, but obsessive-compulsive disorder at F42 is a category. Really, we couldn't put it near that. So our solution was to place it under the more non-specific grouping of other non-psychotic mental disorders, which is F48, which is sort of a spot where you could put, like hoarding disorder is a non-psychotic mental disorder, and it seemed to make the most sense to put it there. And there's an open code there, F48.3. So our proposal for hoarding disorder would be that the F48.3 code, which is currently not assigned to any category, be assigned to hoarding disorder. And the last piece of it is that DSM-5, because of the structure of, let me go back to here. So DSM-5 has this grouping called obsessive-compulsive and related disorders, and because of that, we have an other obsessive-compulsive and related disorder and unspecified obsessive-compulsive related disorder. These are two terms which are currently in DSM-5. So the question is, we need to have some crosswalk between ICD-10-CM and those two categories. So the last piece of our proposal was to have the crosswalk go to F48.8. So our last part of our proposal is to add other obsessive-compulsive and related disorder and unspecified obsessive-compulsive and related disorder as inclusion terms under F48.8. So this is what the proposal looks like in summary. So for F42, the addition of anancastic neurosis and obsessive-compulsive neurosis, we're simply re-putting back in the inclusion terms that were originally under F42. And you can see we're deleting all of the rest of the things that were under F42, the hoarding and excoriation disorder. And then under F48, we're requesting the new code, F48.3 for hoarding disorder. Under F48.8, we're simply requesting the addition of two inclusion terms, other obsessive-compulsive and related disorder and unspecified obsessive-compulsive and related disorder. And then finally, for excoriation disorder, we're putting it into F63, which is impulse disorder. And as I said before, F63.3 is trichotillomania. So we're putting excoriation disorder next to it at F63.4 because those two conditions are very, very similar. And this excludes note is the original excludes note that was that goes with excoriation disorder. I think I've explained this already. So the one unusual part of this proposal is this, clearly where to place other obsessive-compulsive disorder, other obsessive-compulsive and related disorder, and unspecified obsessive-compulsive and related disorder is a bit of a challenge. We need some spot for them, and we're proposing F48.8 as the potentially reasonable, because it is true that other obsessive-compulsive and related disorder and unspecified obsessive-compulsive and related disorder are non-psychotic mental disorders. So technically it does fit there, and there's no other obvious spot for those two categories.
The floor is open for comment.
Jean Yoder, contractor, Defense Health Agency. I don't know how often you're going to see something documented, obsessive compulsive and related disorder. Do people document that a lot?
No, that's a major grouping. That's how nobody would diagnose obsessive compulsive. That's sort of like saying psychotic disorder. It's the same level of abstraction. You know, people don't usually write down psychotic disorder. They write down schizophrenia. So obsessive compulsive and related disorder is the overall umbrella term for those categories.
But see, I don't know that you really need to address this. I mean, maybe somebody thinks you need to address this, but if somebody sees this unspecified obsessive compulsive and related disorder, you're not going to have anything in F42, because they're going to look for the NOS. I mean, that's okay. Never mind. Maybe the other coders don't do that, but it seems pretty popular where I hang out that NOS means put it here. Okay.
Nellie Leon, she's San American Hospital Association. I think Jean is right. Putting that inclusion term under F48.8, unspecified obsessive compulsive and related disorder, makes it sound like if it's not specified, you should be there instead of being at the F42. But I think I have a bigger issue, which is, okay, so hoarding disorder, excoriation, they're fairly new codes. The title of the code is not changing, and now you're totally changing the number. And this goes back to what Jean has been saying all along. What does this do to the data? Because people are going to be looking for this condition, and they're not going to know that, well, for a short period of time it was under F42.3, but guess what? The condition now is F48.3, nothing else has changed. And I think that, the concern about maintaining the integrity of a classification system is valid, and to just change it to a different category altogether, I'm sorry that it didn't go into the right category the first time, and, as a coding professional, it just doesn't seem right to be automatically just deciding to move it around when nothing else has changed. It's not like, clinically the condition now has been determined to be different from what we thought 10 years ago, or anything like that. So, and this is kind of going like, philosophically, it just doesn't seem the right thing to do.
Thank you, Nellie.
I would just add to Nellie's comment that CPT renumbers codes all the time, and it drives me crazy as a coder, and also it drives data analysts crazy. And you have, if you're looking at data over the course of several years, you have to say, okay, well, effective this date it was here, and effective that date it got changed to this. And I understand the impulse to do that because you want things to be orderly, but the change has been made.
There are some people who go to Wikipedia to find diagnosis codes. And if you look up excoriation, I have this horrible feeling I know what code is going to be there. And I don't know how Wikipedia is going to handle this when it changes, okay? And so as an analyst, when somebody says, and Congress does it all the time, because we don't charge when they ask us for data. And so they ask us for lots of stuff. Like how much does it cost for long-term maintenance of sex change operations? So that's why we always send over the information about how long it also costs every year for Viagra. But, okay, so the thing is, when somebody, no, I'm not making this up. I mean, somebody will say, hey, how many people does excoriation? And if somebody has an old coding book, and yes, there are old coding books out there, most of our offices have them. If somebody has an old coding book, they're going to find the old code, and they're going to say this code, and then is somebody going to realize that it's not there for the other years and that something might have happened? No, they're not, okay? So even though it's in the wrong place, you're kind of on that horse, and changing it now is going, but here's the other thing. The sooner you change it, the better, and you get it done and over with, okay? So,
Now.
Good luck with that.
Thank you.
Hi, June Bronner with Intelligent Medical Objects, and I agree with the comments that have been said about changing the code, because if those codes become deprecated, my additional comment would be that they're deprecated permanently and not renamed along the way to something else, because I think that would continue to add to the confusion of, for this period of time, they had this code title with this code, and now there's this code with that title from that data perspective and the integrity of the system.
So can I make one? So it sounds like this is a cost-benefit thing. It sounds like there's a problem, and our solution is worse than having the problem. Is that the consensus, I guess?
Very good diagnosis, right?
Hoarding and excoriation, they're relatively new, able to be captured. So if we're going to change it, you got to do it just as fast as you can. And 5 years from now, nobody will even care, because usually they don't ask for requests more than 5 years back, unless they're really, don't worry, some people want to go back into 30 years of our data, but generally 5 years is what we do. Well, there'll be 5 years of people saying, oh, well, the excoriation came in, here it is, and it only goes back 3 years, and that's what we're going to give Congress if we don't realize that there was a year when it was someplace else. If you're going to change it, you better do it now, and I don't see excoriation and hoarding going away anytime soon, okay? And so don't, that F42, I don't know what you're going to do about that, but if you're going to move things, get it done, and it'll be forgotten in 5 years. But people with the condition are still going to get diagnosed with it, because you're going to still be being treated with it, right? So this isn't, hoarding doesn't usually go away overnight. And so if they've had it for the last 2 years, there's a good chance that they'll have the new diagnosis, and you'll still be able to pick them up.
Yeah, I just want to speak in support of those who do not think these conditions should be moved. I don't know if it's the pizza I had for lunch or not, but I'm starting to get heartburn. And I think it's because, this to me violates everything we've all learned about classification systems, and I think the way Dr. First put it, where the solution is worse than the problem. But while we're getting hung up on the movement of the hoarding and excoriation disorder codes, I also wanted to support Nellie's, and I think someone else made the comment about the proposed inclusion terms for other obsessive-compulsive and related disorder, which nobody, as Jean I think mentioned, nobody documents that. And I think we could run into a problem where people think unspecified obsessive-compulsive disorder goes wherever that inclusion term is. I don't think that inclusion term is helpful at all. I think defaults, index entries, and so on will take care of any other conditions that might not be specifically coded.
Wow.
Okay.
Wow.
You want phone people
get the phones. But I just want to remind everybody, you've given us a lot of things to consider, and Dr. First and I have had lots of interchanges while he was on travel trying to sort all of this out. And we did make note that we felt that there was going to be some concern regarding those inclusion notes on where we proposed to add them. So please put everything in writing so we can have the big picture and send those to us sooner versus later. And moderator, could you open the phone lines, please? Moderator?
Yes, I'm here.
Okay, could you open the phone lines real quick, please?
All of them?
Yes.
Okay, no problem. Give me 1 second.
Certainly. Are there any questions or comments from the phone lines, please? Not hearing any. That takes care of our mental health proposals. And Dr. First and I, we will continue to work. And please give us your comments and stuff in writing so we can definitely try to iron out what our next step should be in trying to fix these 3 proposals. So thank you, Dr. First. Thank you. And now I will turn the podium back over to Shannon. Urology.
Okay, so our next topic can be found on page 12. It's abnormal findings of diagnostic imaging of testes. And this was a submission from AUA. Make sure, is there anyone here from AUA? I know they were attending, but I'm not sure if there was a problem with schedule. So we're going to go ahead and go through the proposal. And if there are any clinical questions, if they come in, we will go ahead and allow them that opportunity to answer them. Otherwise, I will take back any clinical questions and we can go through the tabular modifications. So on this proposal, I'll let you read the background piece and focus more so on the coding portion. And it says that the available codes in ICD-10 are for abnormal urology, urologic imaging of testicular cancer. Currently, there is no unique code for reporting abnormal findings of diagnostic imaging of testes. They are proposing the following new tabular modifications. Add category R93, abnormal findings of diagnostic imaging of other body structures. Add code R93.8 to delete the following inclusion terms: abnormal findings of radioisotope localization of placenta, abnormal radiological finding in skin and subcutaneous tissue, mediastinal shift, to add a new subcategory, R93.81, abnormal radiologic findings of diagnostic imaging of the testes, with new codes for right, left, bilateral, and unspecified testes. A new code R93.89 for abnormal findings of diagnostic imaging of other specified body structures, with inclusion terms: abnormal findings of radioisotope localization of placenta, abnormal radiological finding in skin and subcutaneous tissue, and mediastinal shift. Are there any questions or comments here in the room?
Jean Yoder, contractor to Defense Health Agency. I'm I'm trying to think about when this would be used, because if somebody comes in for an appointment, they come in for pain, or they come in for a mass, or they come in for some reason, and that has a diagnosis, and then the provider orders this radiology study, the patient goes home, and then the doctor reads the findings, and says, hey, there's something abnormal here. And so then they call the patient back, and they say, hey, I think you're going to have to come in, and we're going to have to do something else. And so I suppose you could code that the reason that they came was because of the abnormal radiology findings, but the real reason they came was because of whatever had brought them in the first time, the pain or the mass or whatever it is. And so I don't know that this would really add to the information about the patient, because you can see that they had the diagnostic imaging study. There's going to be a CPT code. You're going to be able to see that, or I suppose if they were an inpatient, you wouldn't be able to, but you could, if you were a doctor, you could tell it was ordered, and you sure wouldn't put this on an inpatient record. Well, I mean, would you guys? Okay, never mind. I don't think it's going to significantly impact the hospitalization. And so I'm not really sure why we would code this.
Okay, thank you. And Ms. Schroeder, if you could please make sure you put that in writing, because they are not in the room, so I want to make sure that we can share those comments. So I need you to put that in writing, please.
Lynn Keene, Keene Consulting. I'm wondering if we missed an important detail in the first paragraph that says patients sometimes have an abnormality that is found on other testing, like it's something they didn't expect. There is no symptom that they now have to investigate further. So once either they show up or you're able to go back to them, maybe that is why they are asking for this. Otherwise, there's no symptom to code the additional testing that has to come up.
That is true. Very good point.
That's a possibility.
Very good point. Any other comments, questions here in the room? Moderator, could you please open the lines for any questions or comments?
Please.
I need it. Hi, this is Dr. Reamer.
Yes.
So the answer is yes, both incidental, or like if a patient comes to the emergency department and they have some sort of testing done, and then they get sent for follow-up, they may not any longer have the pain or whatever that brought them into the emergency department.
Yeah. Do real letterhead.
Dr. Reamer, is there any way that you could repeat that? We were able to hear the first part of what you said, and afterwards there was a lot of background noise.
I know. There's somebody else with there who's unmuted.
Sorry, I'm trying to listen, but
they don't know that they're unmuted.
Okay.
So anyway, yes, I can. So the incidental finding, and also if a patient comes to the emergency department for some complaint, and then they have imaging done, and then they get sent for follow-up to the specialist, like the urologist, because they found something on the imaging. So they may not have the complaint that they had in the emergency department anymore, but now they have. I'm really sorry. I don't know who's talking behind me. It's not in my office.
Okay.
Okay.
So can you, Dr. Reamer, can you please place those comments in writing and send them in to us?
Yeah, I was just trying to explain to Dean what the reason would be for using those codes.
Okay. Right, thank you. That was very helpful. Okay. If you could please go ahead and mute the lines. I'm going to go ahead and move to the next topic. Moderator, could you please go ahead?
With you up there.
Is there a comment?
I didn't understand what you said.
Moderator, could you please mute the lines again, please?
Yes, ma'am.
Okay. Stay here, Chris.
My apologies there. We're going to go ahead and go to the next topic. on page 13. The topic is abnormal levels in urine collection. This is a representation. The proposal has been revised based on public comments received following the March 2016 Coordination and Maintenance meeting. So the existing code E72.53, hyperauxiliaria, is for a childhood inborn era of metabolism, primary hyperauxiliaria, which is a diagnostic condition that can be determined by genetic testing. This is different than someone who has had an idiopathic and diet-induced mild elevation of oxalate in the urine who does not have the genetic inborn era of metabolism. AUA is requesting the following ICD-10 CM tabular modifications, and the changes are shown in bold print. So at category E72, other disorders of amino acid metabolism, we're revising the code title E72.53 to read primary hyperauxiliaria. Previously, this was just the hyperauxiliaria, and realizing that now those two codes would share the same title, we needed to revise that code title for at least the E code E72.53. At category R82, other and unspecified abnormal findings in urine, we have previously proposed deleting the inclusion terms, cells and casting urine, crystalluria, and melanuria. The same new codes, and then the portion in bold would be proposed here as well, the new code R82.991 for hypocytruria, new code R82.992 for hyperoxaluria, the inclusion term being at that code level, and to read excludes 1 for the primary hyperoxaluria. Adding a new code R82.993 for hyperuricosuria, a new code R82.994 for hypercalciuria, and a new code R82.998, other abnormal findings in urine, with the inclusion terms for cells and casting urine, crystalluria, and melanuria. Are there any questions or comments on this proposal? Okay, moderator, would you please open the lines for any questions or comments?
Has been unmuted.
Are there any questions?
Hi, this is
Dr. Reamer?
Yeah, this is Dr. Reamer. Can you screen back, scroll back to the last one, the last slide?
Last line?
Yeah.
For the...
Before the hyperuricosuria.
Okay, so here... Under the excludes note, under the hyperoxaluria, or further up?
Further up, I don't know. I can only see right now, I can only see new code R82.993. There was a question I had about one that was hypo, and I'm wondering, is that really hypo or supposed to be hyper?
There is a hypocytruria at R82.991.
Which is sort of interesting, because is there like a normal value that one is supposed to have in their urine? I'm just not familiar with it. If that's the case, that's fine. I was just wondering if that was supposed to be hyper.
No, it's correct as hypo, but I will double check with Dr. Rubenstein just to confirm the range that is expected for the normal range.
Okay, thank you.
Thank you. Are there any other questions or comments on the line? Okay, one more comment question here in the room.
Can I just ask Dr. Reamer to repeat her question?
Oh, sure.
I didn't quite understand what the concern was. Thank you.
Dr. Reamer, could you please repeat the question? You have someone in the audience that would like to hear it again?
Sure. So generally speaking, when you have conditions that are either hypo or hyper, there's a normal range that one expects or desires to have in the urine or in the blood or whatever. And so if you have an abnormal, it's outside of the normal range.
And I just personally am not familiar with a normal level of I'm presuming citric acid in the urine such that one would detect it being too low, what the implication would be of that. So I was questioning whether it was really supposed to be HYPER, because generally speaking, when you find something abnormal that you don't expect to be in the urine, it's usually hyper.
Are we good? Okay. All right. Thank you. Okay, moderator, you can go ahead and mute the lines, and we will go to, this is the last proposal that we received from AUA on page 59. The topic is neoplasm, unspecified behavior of testes, and it says a patient may present with a growth or mass of the testicle detected by examination or by an imaging study performed for genitourinary or non-genitourinary reasons, and further testing and/or procedures would be indicated. The differential diagnosis includes a variety of both malignant and non-malignant conditions. AUA is requesting the following new codes to accurately describe the situation. Where a neoplasm is discovered on the testicle and tissue has not yet been obtained to make a diagnosis. Would you like for me to go through the coding tabulation proposed changes, or would you like to go ahead?
Well, I grew up a long time ago, and I was always told that if there was a mass, it was a mass until they did the biopsy and they found out that it was something else, that this unspecified behavior was for some kind of a neoplasm that was acting in an abnormal way, and it was a real honest-to-goodness neoplasm kind of thing as opposed to a mass. And so even though people write down depression, it might not really mean depression, okay? And so just because they write it down that it's a new growth, it doesn't mean that it falls under the neoplasm chapter. But that was perhaps that I learned in 1982 when I was learning this stuff, and maybe it's changed now. But I never thought that we were supposed to code a neoplasm and stick a C or a D code on anything until we had really had some kind of definitive finding.
Thanks. And I actually, as I'm looking at this, I believe that there is probably further detail that AUA would like to share with us with the background on this. With their expectation that there would be someone here today, I believe that may be the reason that we have this abbreviated background write-up. But I have your point, Jean. So I'm going to go ahead and walk through the tabular modifications proposed. At category D49, neoplasm of unspecified behavior. At subcategory D49.5, to create a new subcategory D49.52 for neoplasm of unspecified behavior of testes, and new codes to report the laterality, right, left, bilateral, and unspecified. Going to open the floor up for any coding questions, and I will definitely take back your concern of what more may have possibly been shared with us to understand the need for their request in that particular section. Okay. Any comments, questions in the room? Moderator, could you please open the lines for any questions? Moderator, could you open the lines, please?
All lines are unmuted. Hey, this is Dr. Reamer, and sorry that I'm going backwards for just a second because I Googled hypocitraturia, and it was basically if patients form stones, you want them to put out a certain amount of citrate in the urine, and if they don't put out that amount, it may leave them prone to creating stones. So it really is supposed to be HYPO. So I retract everything I said. This is what happens when an emergency physician tries meddling in things she don't know about. Thanks.
No problem. I did look on his proposal he sent in, and it was hypo, but thanks for the confirmation and all. Appreciate it. Yes.
Okay, now can we go back to what Jean was saying, at the D49? I agree that there isn't, there aren't codes at the D49 for these unspecified behavior neoplasms. However, when I look at the rationale given by the AUA, I think they're not understanding this classification because as I read that, kind of like the bottom of that last paragraph, where they think that they're looking for codes where the tissue has not yet been obtained to make a diagnosis. So that is not a neoplasm of unspecified behavior. I think what they're looking for is it's kind of like what we have for like lump of the breast or mass of the breast, which you don't know. So because you haven't done the biopsy yet. And so while I don't disagree with expanding the D49.5 codes to be more specific, I think they need to understand that these codes were not meant for, you know, I don't know what the what the cell type is or what kind of tumor this is.
Okay. Thank you. Any other comments? Okay, hearing none, I am going to turn the podium back over to Donna Pickett.
Well, I tried to find some more proposals that we could cover this afternoon, but we don't have any. So you actually get a bit of a break for the afternoon. We will start tomorrow morning at 9 a.m. We have about 14 or 15 proposals. Most of them are pediatric related, and our presenter, submitter, Dr. Linzer from the American Academy of Pediatrics will join us tomorrow, but he couldn't be here today. So all of those issues are being held for tomorrow. And we have a few other presenters who also couldn't be here today. So you get some time back. And hopefully the weather holds up so you can get where you're going without getting too wet. Enjoy your evening, and we'll see you tomorrow morning.